if you've never presented on Zoom, when you're sharing your screen, you don't get to see all the other things. Like if you're watching, like right now, you'll probably see everyone's names in my one photograph, but I don't get to see that when you're in the presenter view. So if I miss any comments, please someone speak up or say something so I can address those if there's like a question or something. Pretty please? Yes? Okay. Someone sent a message. Kent, you got a copy on that?
Copy. Inboard.
All right, well, it's 5 o'clock. Looks like we got a good crowd forming. So first of all, I want to thank you all for joining us. Good evening to you if I haven't seen you today, if you're not working. If you're coming from us live at home, thanks for joining us. This is our first presentation of 2024. We're all excited to have this back. I appreciate you guys, all your input and feedback to keep it alive and going. Actually, one of the comments from one of the corporate educators was when I sent them the results, they were very impressed that it's a successful program. So again, I appreciate your guys' feedback, filling out the evaluations. Like I said, I'm running solo tonight, so if I miss a comment in the box or anything, someone please speak up or say something to me, because if not, I'm just going to keep trucking through this. The theme, so I thought about a theme this year based off your guys' feedback, and there was a numerous, I think it was 51 of you that replied to the survey with numerous topics, and trying to combine them all separately is a challenge. But I could pick out some themes, and one of the themes obviously is ventilator management. And I thought we would start the year off with the basics first, because I know we still have a lot of new therapists that are either just graduated into the ICU, maybe only been in the ICU for a few months, or are getting ready to go to the ICU. And then again, we have our experienced people, our mentors and preceptors, obviously helping them. But I thought we'd go back to the basics. Recently when I do some rounds in the ICUs, I see some things that I enjoy teaching about and educating. And with a bigger audience on a case study like this is a lot easier than individual one-on-one. So tonight, that's our course, what we're going to talk about. We're going to go back to the basics and just review some basic settings and initial changes, based off of our gas exchange, and go from there. Hopefully we can spark up a good dialogue tonight about this.
I'm presenting family for H.
So again, I do have control to mute people though that are not unmuted. So let me know who it is. All right, so at the end of this presentation, again, I had to have learning objectives for a CE course. So we're going to talk about how to select those initial settings, including the mode and the parameters. We do have a mechanical ventilation policy and guidelines. And again, we would need to compare that to provider preference. And what I mean by that is, some docs want to do their own method or strategies, whether it's evidence-based or not. From us standpoint, we have to set aside our opinions of what we think is the best and follow the data, right? Follow the research. So we want to eliminate that bias, that implicit bias from that. And I have to have that in every education. I can talk to you guys about it later if you want, but it has to be in there. Determine when to make vent changes from the data they collected. So when you're doing your patient ventilator synchrony assessment, or PVSA, and you do have a blood gas or collected a blood gas, what changes are you going to make on the ventilator, if any at all, are needed? And then, how to identify when to start the weaning process. I think I've made this, I don't want to call it a joke, but I think I've made this statement several times where it's pretty straightforward. Patients in respiratory failure, we intubate them, secure the airway, we place them on a vent, we set them up based off our experience, we get a blood gas in an hour, it looks good, everybody's high five, and we're done. And in my opinion, we're not done, right? Because now what is our goal is we got to get them off as fast as we can. And tonight I want to try to point out some times of what to look for, when should alert the RT to say, hey, you know what, it's time to start weaning this patient from these settings. These settings were set up 2 days ago based off a blood gas over there. But now here we are 3 days later, what's different about the patient now and how do we make the changes? That's kind of my big focus tonight is how do we make those changes? Oh, and then also it says to prevent unplanned extubations. So as a special data surprise for you guys today, I'm going to share with you our unplanned extubation data for 2023. And you might be shocked. You might be shocked to see what's going on out there. And it kind of goes hand in hand, like I said, about are we identifying weaning soon enough? So mechanical ventilation is one of those, it's one of those topics that's sometimes confusing and overcomplicated, or other people make it overcomplicated, especially in our field, whether it's, whether you're a nurse, physician, or provider, or therapist, somewhere in your education, you might get told a different definition of what volume control is versus pressure control, or what is the best mode. Whatever it is, let's not overcomplicate it. Let's keep it simplified and keep it to what's best for the patient. Okay. It is common for types of these medical professionals working in critical environments to be intimidated by ventilators. And I can tell you, I get told quite a few times if I walk in a room and I see like multiple things, I want to get going on changing things. And I forget that based off my years of experience, for someone who's new to the field, I got to slow down for a minute and explain what I'm seeing and why I'm seeing that and what changes. Because I know it based off intimidating, if you get a blood gas and say whatever's high or low, whatever you need to make a change on your gas exchange, that the therapist with not a lot of experience isn't that comfortable making multiple changes. And so they'll do one change at a time, or they'll titrate something only by ones or twos or whatever it is. And that's what I want to kind of just focus on tonight, is make sure we're comfortable with making those changes and know when to be more aggressive versus conservative on making those changes. Now, most of us should know basic indications for mechanical ventilation. The biggest thing is either we're providing this ventilator or blower to fix gas exchange. It's either respiratory failure due to hypoxemia or respiratory failure due to hypercapnia, or it's just an airway protection device, depending on whatever, I don't know why I said device, but whatever the situation is, our patients in respiratory failure, we need to intubate them, we need to secure their airway and put them on this ventilator. But the one thing, every time we talk about indications, we always have contraindications. And does anybody want to tell me what is a contraindication for mechanical ventilation or positive pressure ventilation, whichever term you want to use? Anybody have one? I'll just sit here and get on my phone for a few minutes while I wait for an answer. Over. Anybody? It's kind of a weird topic, right? You might have to look them up real quick because you're thinking to yourself, what is a? Well, there's two most common ones that are. Oh, go ahead. Go ahead.
Well, I was just gonna say, if they don't have a chest tube and they have a tension pneumo, that would be a contraindication.
I don't think.
Go ahead, Nicole. I can't hear you. You're breaking up. Joe, I heard your answer.
How about if someone has a low blood pressure?
I think most of our patients that are in sepsis or septic shock or any type of shock are going to get intubated, put on a vent with, right? They'll be hypotensive, but they'll be on pressors, right? We can fix that with pressors. Yes, the high positive pressure can cause more pressure problems, but we'll use medication for that. See, that's the tricky part about this. It's not as much as a clinical question. What if I roll up into the ED and I have my advanced directive with me? And it says, I'm a DNR, DNI. I don't want to be intubated. I don't want to be on a ventilator. Don't we have to respect that wish?
Yeah.
So that's kind of, if you look at, and I tried to look this up several times just to see out there. And it's basically, yeah, it's either someone saying, no, I don't want that, or it's a situation where we shouldn't intubate them and put them on a vent because of the outcome is not going to be poor. But that's really it. I mean, all those other things you guys mentioned, I mean, Joe with a pneumo, we can put a chest tube in while they're on a vent, right? We can still ventilate them with that. I mentioned the hypotension. I mean, still manage that with medications. But those are not times where you say, hold on a minute, we're not going to put them on a vent because of that. But I thought it was interesting to look it up because every time we have that situation, we don't talk about when do we not put them on a vent, because I think it happens more frequently than we think about. So since we're talking about ventilators tonight, you know, there is a majority of ventilators out there, and really the take home message that I remember this quote, and I can't remember who said it. Maybe John, if John's on the line, if he remembers, but somebody said the best ventilator out there is the one that you have, right? If you're at a facility and you've got one vent, then you need to be an expert on that one vent. You need to know it inside and out, upside down, sideways, whatever, to do that. That's the best vent out there, is the one that you have available to you. I mean, if you had the luxury of having every single type of ventilator for every type of situation, which I don't think there's many, that most of them all pretty much do the same thing, besides proprietary you know, parameters or modes, then really the focus tonight again is not what's the best vent out there, but the person that's operating it and the settings and changes that they're making. Most of us here, if you're community employees here, should know that this is our 3 ventilators that you should be used to using day in and day out, right? You get the Servo U's, both at CRMC, Fresno Heart, and at Clovis. We got the 980s out at Clovis, and all 3 facilities have the Hamilton T1, right? And they all do that. So when we talk about terminology, assist control ventilation, and I know, I apologize if some of this is a little bit basic, but let's just, like I said, we're back to the basics. Let's remember what types of breath types we're delivering with the vent. And you can either have a control breath or an assisted breath, right? And I like the 980 how it does it, because it has that nice big green, bright, vibrant C up at the left corner there that tells you, hey, that's a controlled breath. Okay, because again, those are, remember, the focus tonight is at the bedside looking at these things during your patient ventilator synchrony assessment. And when I'm looking at the bedside, looking at this like a controlled breath, I see the rate is 18, they're breathing 18. Okay, I usually like to have my patients breathing above the vent if they can, if it's possible. So again, those are the things that are going through my mind already, just looking at the settings. Let's say you wean down let's say we wean down the rate to 12, we come back half an hour, the patient's starting to do assisted breaths now. Well, then now what we can see, somebody needs to mute their phone, please. So now when you see the big A, so that C is changed to an A. And again, I like the graphics of this because it makes it very easy to see from a longer distance that you can actually know if it's an assisted breath versus a control breath. Sorry, somebody's not muted. It's distracting me. Okay, so SIMV, I'm not going to talk about. We don't use that mode very often. But again, you would have spontaneous and control on that if you did. But again, if you're in a spontaneous mode, again, I like the 980, how it displays the red. It gives a different color red, and it tells you a big S for spontaneous. And again, the colors change, you know, and between white or triggered breath over here, it changes to a red from a trigger. So I like that changes on the event to make it different. Now, again, these are the breath types. If you look at volume versus pressure, I'm not here to argue and tell you one's better than the other, but the biggest thing that we need to know is when to use them and understand them and explain them. And if you think of volume ventilation, well, volume is constant. So that means we set a tidal volume, and pressure is variable based off lung compliance. So if we look at the pressure volume curve, okay, when your pressure is on your horizontal axis and your vertical axis is your compliance, remember, compliance is change of volume over pressure. Okay, so as our compliance goes down, our pressure starts increasing to the right, but our volume is constant. It never goes above the volume. And it's the opposite for pressure. Okay, if we're in pressure control and we're setting a pressure, then you can see here we're not exceeding that pressure because that's our limit. However, your PV curve or volume loop is going to start going downward, or loss of volume, if your lung compliance gets worse. So that's one of those things you need to monitor in pressure control, is to make sure that your tidal volumes are not decreasing throughout your shift when you're charting them. You know, if you started out with 500 cc tidal volume and at the end of your shift you're only doing 350, no changes, nothing's been made, you got to assume that something's changing about your patient, you should assess it and try to figure out what it is. Is it something simple as they've got a plug or a bunch of secretions, you can change them? Is it a positioning thing? Do they have a large abdomen and you've lifted them up past 30 degrees and you're squishing on the abdomen now, which would compress the diaphragm and make your exhale volumes go down? Those are the kind of scenarios to think or take a look at or picture. Or, what I'm trying to avoid is not just document and say, oh, well, I got to get to my next PVSA, and then you move to the next room. That's something that you should address and be able to be alerted to try to investigate a little more what's going on with that. Now, again, I'm not going to focus on either the modes. There's not one best mode that fits everybody, but a lot of times there is a mode that works better than the other in different situations. But there are many modes, and again, remember that the bottom line is they're either a volume mode or based or pressure based mode. Whether they're from the servo, whether they're from the 980, the Puritan Bennett, whether it's VC plus versus PRVC and so forth, they are still going to do the same thing. Now, under the control modes, I like how the vents have it laid out here. And again, for anyone that's new to the ventilators that we don't know, this is a good refresher to show how they lay these out, because it's pretty much simplified if you ever noticed it. Because if you look here in the 980, and I highlighted here in the yellow bar as the mandatory type or the breath type, what is the control part? What do you want controlled? Do you want a pressure breath, a volume breath, or a combination of the two? Okay. If you wanted to go to spontaneous, they have it organized by spontaneous, by trigger type, and then do you want an AC, SIV, or spontaneous? And that's what I like how they organized it. We'll talk about ideal body weight here in a sec. And on the new Servo U, they've done it a little bit different. They've put their control modes at the top. They're interactive, what they call them, okay, or intermediate or interactive modes here in the center, and then your supported modes down at the bottom, okay? And yes, there's some modes on the servo that are not on the 980, and there's some on the 90 not over here. Again, tonight's not the talk to discuss that difference between the two, but to just know your ventilator. Again, your vent is the best vent out there. Know it inside and out, how to set it up, and how to manage it and run it. If you look at the spontaneous modes or support modes, again, the 980 has them right here. Pressure. Anyone want to tell me what TC means? Who's a 980 expert out there? John Yoshida can't answer this question. If he's on there. I don't know if he's on there or not. TC, anybody? It's not tray caller. It's not time compensation. Somebody typed. No type. Anybody? There's 55 people on this. Not one person knows what TC means?
Tube compensation.
Ah, thank you. Tubing compensation, exactly. Okay, again, we're not going to discuss it, what it is. If you want to know later, I can talk about it or someone, but tubing compensation, it's a different, again, proprietary to Puritan Bennett, okay? It's not on the servo. But if you look over in the servo under support, there's a couple of other modes that are proprietary to servo that you won't see on the 980. And again, depending on if you use the servo to know what they are. You have volume support, okay? Not just pressure support, but volume support. If you opened up the settings, you would actually set a tidal volume. So you would still target a tidal volume versus targeting a pressure in that mode. NAVA, again, is for a different lecture, but that stands for Nearly Adjusted Ventilatory Assist, okay? That's the one where you got to put a catheter down their esophagus, and it has receptors on there, and it measures the signal from the brain down the phrenic nerve to the diaphragm, and then alerts the ventilator that the patient's going to trigger a breath. So it's trying to synchronize better with the patient so they can wean them off the patient even faster. It's kind of like some of that fancy technology that's out there. Of course, the catheter is expensive. It's only good for 5 days, so you got to get them weaned off pretty quickly if it's working and to synchronize with it. Okay, from the support. So volume support, again, why you don't see that on any other ventilator besides servo, and this might be trivia to somebody, maybe you don't know this, is volume support was created because of auto mode. So if you look here in the interactive modes here, you have auto mode, pressure control to pressure support, PRVC to volume support, VC to volume support. And the reason why they had to make this is based off the algorithm is you can't go from pressure to volume. You can't go from volume to pressure support. You have to keep it straight across the board from either pressure to pressure volume to volume. So that's why if you're in PRVC with a backup volume of 500, you set up volume support with that same support, you're going to get that across the board when the patient's going back and forth. So again, a lot of you are asking, well, wait, explain to us what is auto mode. So I did fit in auto mode in here because I know a lot of you have been asking. We're starting to use that a little more and more down here at CRMC, especially in the neuro ICU, which I think is one of the perfect populations, which is when I presented it to the providers that was a mode that, you know, the majority of the patients are intubated usually just more for airway protection versus respiratory failure. So a lot of the providers said, well, why can't we leave them in support all day long? You know, and sometimes they have backup, sometimes they don't. And SIMV is a little more complicated to set up to actually have that backup. But if you use auto mode, it allows the patient to go into a true spontaneous mode and supported mode, and they can stay there as long as they want. So deciding on which one to select, again, whether it's going to be pressure oriented or volume oriented, these are your transitions, what it's going to do, where it flips back and forth between the two. And when you open up the vent to set it up, again, this would be PRVC to volume support. A couple of parameters that are different is one is the apnea time. This only goes from 7 to 12 seconds. So what it means is you're just limiting the amount of time. So when you go from control to spontaneous or supported, the next timing, if it goes from support and the patient doesn't take a breath in whatever 7 to 12 seconds you set it at, that's when it will kick back over to PRVC from volume support. There's no alarm, there's no message, there's no nothing. The only thing that you can tell by it doing this is up here at the top, if you can see the screen, hopefully you're all on a computer, you can see the screen. When it's highlighted in white, that's the active mode. Okay, so it's highlighted in PRVC right now. That's what the patients, and you can see there's no triggered breaths. They're active. If you look at when they activate auto mode and go into supported mode, you can see the triggers right here where they're triggering, and then the PRVC grays out and the volume support highlights white. And that means they're active in volume support. Also, if you notice down here that the backup rate of 10 grays out also. And that's, again, just another parameter to let you know. Here you can see it's highlighted in white. Maybe you can see it, maybe not. I don't know if you're on your phones or computers, but it's highlighted white here. When they go into volume support, then it grays out here also. Because again, they're setting their own rate in time right now. Again, just another way to look at it when it's flipping back and forth. But again, there's no message, there's no alarm. You could be in the middle of your PVSA charting the settings on this, and they could be flipping back and forth on you in 7 seconds, right? So there's really no way to monitor this or manage it. You can't go back in the trends and tell how many times it went back and forth. So it's really a mode that I would suggest using as a tool to see if they can spontaneously breathe and hold their own. You know, one tip would be if you put them in auto mode and they started breathing 30, 40, 50 times a minute, obviously they're not tolerating, think of it as a spontaneous breathing trial. Then I would flip them back and put them just back into an assist control mode. They're not ready for auto mode yet. But again, it's another, back when I was first introduced to it, that's the way we used it, is we would turn auto mode on and just see if they can initiate spontaneous breath. We would still move forward to spontaneous trials, but it just kind of give you that extra, you know, instead of doing assisted breaths and control, it allowed them to do a spontaneous breath, but it still give you an idea or a clue that, okay, they're ready, they're good to go for an SBT, or they're not good to go, and you can trial it out. Now, some of the contraindications when you don't want to use auto mode is obviously if they don't have a drive to breathe, they can't initiate a spontaneous breath or cannot trigger for some reason. If they're severely ill and acute lung injury, or if we now call either moderate or severe ARDS, septic shock, you know, at risk for ARDS, where their mean airway pressure is decreasing, we have to turn up settings, then I would not suggest putting your patient in auto mode in that situation either. And again, you may have a provider that either disagrees, doesn't want to use it, doesn't understand it. Again, not all of them, even though I've given probably several classes to each service, you know, not everyone remembers how it works or use. My best advice to you guys, if you understand it, have a good enough understanding of it to explain it at the bedside, is the easiest thing to show them is when you set it up to settings and place it in auto mode, immediately when they trigger a breath, they automatically switch right over. It only takes one breath, and you could show them their work of breathing and spontaneous, and then let them know that within, when you change it to 7 or 12 seconds here as the apnea time, they're always going to provide it with these backup settings here. Make sure I'm doing okay on time. No questions, comments. Let me double check. Nobody chatting anything. All right. Moving on. So one of the bigger questions that I've gotten recently is, what do you document, or how do you document, or what do you document when a patient's in auto mode? And the way I view this is you have settings, measurements, and alarms in your flow sheet, right? So all these settings here, I would document, whether they're in PRVC or volume support, because again, you don't know when that patient's flipping back and forth. They could be in volume support when you're doing your check, and 2 minutes later, they're back in PRVC for whatever reason. Again, that's going to be hard to determine. So I would document everything, all the control settings. Your apnea is going to be in the alarm section, and just chart all of these here, what's set, and then document down here. Now there is a button here, and again, it may be misleading here, but here's the way to interpret. If it says auto/backup mode, okay, what that means is it's a yes or no question, and I know that's a little confusing, but the way that I would read this is, if you selected yes, that would tell me that they're in auto mode. They're in the spontaneous section. / would be the second option. So if they're in the backup or PRVC option, then I would put an N for no here. I'll say that again if you missed that. If they're in auto mode, I would select yes. If they're in the backup mode or PRVC. And I know some are interpreting it as like, oh, they're in pressure support with a backup mode. But again, remember what you're charting up here. You're charting auto mode, pressure control, pressure support. You're not charting pressure support up here. You're charting auto mode PC with PS. So now under these settings, this auto and backup mode means that the backup mode would be PRVC. Auto mode would be if they're in volume support. Or I gave you the wrong example here, but pressure control. The backup mode would be pressure control. That'd be the no. The yes would be if they're in pressure support. Okay. So use that as a guide to select there, but I would fill in all of your settings and measurements that you have available to you, because like I said, as often as these patients are switching back and forth, you're not going to be able to tell or sustain which mode they were actually in when you charted versus what they're in at that time. Now, here we go with the settings. I'm going to start here with predicted body weight. And the reason why I want to start here is I know that we're not consistent in this. And it tells me this when I show a physician at the bedside, when they're questioning, if you're in pressure control, like I said, you're not targeting a tidal volume. So when they're questioning how many mLs per kilo ideal body weight is the tidal volume, they're not sure. And I said, well, I can show you what it is right now if we put in predicted body weight. So again, whatever ventilator you use, both ventilators have this option to do this. And it's usually right at the beginning when you turn the vent on. Right here on the left of the 980, when you turn it on, you've got this little section on the left. Male or female, what is their height, either in inches or centimeters? And it will give you their predicted body weight. On the servo, it's up here on the top. Again, when you open it up, you just push that on the screen. Open it up here, male or female. A lot of times you can just put the height in. You don't have to put their actual weight in, but just put in their height there and you'll get predicted body weight. Because sometimes you'll notice that, like if you want to turn on servo compass or one of the other advanced screen monitors, it won't do it unless you put in predicted body weight. Anyone ever got that message before? You're like, oh, it won't let me show it because it tells you to do that. So I would recommend get in the habit every time you're setting up a new ventilator, put in that ideal body weight right away, and then you don't have to worry about it. Also, it'll be on the screen. For the servo, it automatically populates down here in the corner. Now, again, depending if you have end-tidal CO2, it might move it off the side, but it's going to be readily available so that someone can look at it and see it and identify it. For the 980, it's going to be, I don't know. I need a screenshot here. Don't watch the screen real quick. Where's one of the measurement? Do I have a measurement for the 980? Do you guys remember one? Right up here. It'll be up on the top bar here. So what you would do is you would double tap one of these here that you don't need. Like you don't need plateau pressure up here because you get that under the hold. what total PEEP, whatever's up here, you can replace that, double tap it, go all the way to the right, last one, it says VTE exhaled volume / PBW. And then you can put that up there and you can have that on top of the ventilator. So again, so if the provider wants to know, hey, I wonder what the ml tidal volumes are, because again, based off compliance, pressure control is not going to guarantee a tidal volume. So up and down, depending on the patient's illness, it could go up or it could go down and vary. So you'd be able to track that a lot easier, and you can tell them, you say, hey, we're still running 6 to 7 mLs per kilo. Take a look right here. This is where we're at. So starting a new ventilator, start with PBW, ideal body weight, predicted body weight. They're synonymous. They're the same thing. Put those into the vent. Okay. Now, initial vent settings. Instead of listing you a parameters here or numbers, because a lot of you already know these parameters, let's talk about first what you would be doing based off your experience. Okay. So again, on the call right now, awesome. We have 59 people on here right now. We have all levels of experience on this call right now, right? From anywhere from maybe 6 months to a year, all the way up to 20, 30. Who's the highest on right now? Kent, how long you been here? You still there? Over?
5 o'clock.
So with all the experience on this call right now, I hear you. So give you a scenario. Okay, patient's going to get intubated, put on a ventilator. How many of you are already thinking what settings based off the condition of the patient that you're going to set them up on? Everyone's hand raising? There's a code on the floor, right? Rapid response, code blue to the floor. Patient's resuscitated, intubated, transferred to the ICU. What would your first blood gas, what would you expect your blood gas results to be post code? Anybody? Please talk to me.
Acidotic with a high CO2.
So probably some kind of severe acidosis, right, Cameron?
Yeah.
And that's probably going to be combined, not just respiratory. A lot of times you're going to have a combined metabolic, right? So if you anticipate you're going to have a high acidosis, then you're going to put them on a rate of 10, 6 ml tidal volume, PEEP of 5, 100%. Or are you going to ramp that up a little bit? Again, that's the focus of tonight. Based off your amount of experience, you're already going to have those settings in your mind, what you're going to put them on. And that's what I want to focus on. The more experience you gain, the easier it's going to come. And the more exposure of these different types of patients and disease states that you'll see, it'll make it a lot easier to set them up. And again, sometimes you don't know, stick to the basics, stick to the basics, and I'll show you the basic parameters. If you're not sure or you're not sure what's going on with the patient yet, there's always some basic bottom line parameters you can always set them on. And again, if it's not your experience, then, what is the cause of respiratory failure or airway protection? If it's a neuro patient coming in that's a stroke and altered and went to the OR for a crane and comes back to the ICU that's still intubated for airway protection, what type of settings you're going to put that patient on? They should have good lungs, right? They're not here for respiratory failure. So based off their pulmonary history, they got decent lungs, then I'm not going to crank up the settings on them. I don't need to overventilate them. Again, that's why auto mode works really good, because as soon as they start working up, just let them go in auto mode. There's no better way for a patient to have their pH and CO2 normalized as if you let them breathe on their own. Again, that's just a pro tip tonight. The other one is physician preference, right? How many of you guys ran into this? Oh, Dr. Wade's on today, and he likes pressure control on everybody. Or what Dr. Wade likes PEEP of 10 on everybody, regardless of what their problem is. You're always going to have physician preference or service, right? It could be a service thing. On this floor, we do this. On this floor, we do that. Or this ICU, we do this. Whatever it is, those are things that we need to adapt to and understand and learn. But remember, us as the experts on mechanical ventilation, a lot of times the providers are relying on us to know what we're doing and how we're setting up that ventilator correctly, and then getting those blood gases immediately so we know, are we going the right way or are we needing to make changes? And again, that's my scenarios tonight, because I'll reiterate it many times tonight. It's not happening consistently. Now, if you want to know the basic settings, you're going to pick either a volume or pressure mode. Your tidal volume, the gold standard, set it up 6 to 8 mLs per kilo. Again, if you put in that predicted body weight, this makes it a lot easier. If you saw the other little, this right here, this is off the servo. If you have predicted body weight in the machine, when you're adjusting the tidal volume, right next door, right here, right next door, it's telling you where they're at. The 980 does the same thing. It's right there. It tells you, you don't have to guess. You don't have to pull your papers out. You don't have to look it up. As soon as you put in predicted body weight, it's all right there in front of you. Right there. Okay, where was I? Let's see, rate. Normal rate for adults is somewhere between 10 and 14. That's recommended out of the 3 basic principles of mechanical ventilation books that I looked at and read to put this together. Again, again, these are just basic settings starting. If you don't know what's wrong with the patient, they just came in, these are good starting points. Again, back to that post code that Cameron meant, Cameron's not going to put him on a rate of 10. He's probably going to put him on a rate of 20 to 24 due to the severe acidosis. He knows he's going to have to ventilate that patient and fix that pH. Okay, that's what I meant by the experience and the cause of respiratory failure. PEEPs, again, based off our guidelines, 5 to 10. What's everybody's favorite number, by the way? Let's see if can you guys see my numbers? I got that
8.
right? Did I got that right? So PEEP 5 to 10, FiO₂, we're going to try to keep that sats greater than, 95 is a good number if you don't know or have an order yet, just for all around. And again, the eye time, normal eye time for adults is somewhere between 0.8. Again, this is an adult talk. We'll have Chris or someone else come back and do your peds ventilation. 0.8 to 1, again, is the recommended. And I have another slide that explains that more in detail. But these are kind of those parameters. If you're not sure what's going on with the patient, then here's your good starting points to set them up. Again, get your gas and then go from there where you're at. Okay. Don't forget about your non-invasive monitoring tools. Most of all of our ICUs or ventilators have the capability to monitor SpO2 and end tidal. I know we're good at monitoring SpO2. We're getting better with our new pulse oximetry products, but also don't forget about end tidal CO2. Okay, to monitor your ventilation, especially if you're not getting routine blood gases, then it wouldn't hurt to put in end tidal CO2 in line just to monitor and see where you're at. Thank you, Claudia. So Claudia made a great comment. Of course, make sure that you have orders or get orders for mechanical ventilation, depending on the situation. I know I always forget the orders. She's always on me that. I'm always on the clinical side. She's like, don't forget your orders. Okay, vent changes. So I thought this would be a little activity here. Let's match the terms, what are commonly seen or known in the ICUs. So if we said the PEEP is too low, what could that be potentially causing or harmful to our patients if we don't have our PEEP optimized?
Atelectasis.
Kent says collapse atelectasis. That is correct. Thank you, Kent. All right, next one. Peak inspiratory pressure or PIP is too high. I'm hoping if we have any nurses on board, have you ever went into your patient's room, the RT sitting over in the corner with its face, they're buried up into the ventilator and your blood pressure is dropping or dumping. And you're like, what are you doing to my blood pressure? Has that happened to anybody or any RTs out there want to admit that that's happened to them? So they might be increasing either too much mean airway pressure or peak inspiratory pressure. What could that be causing?
A pneumo.
Okay, from a barotrauma standpoint, that's good. That's a good answer. But let's select right here on the screen if you guys can see the screen. Which one of these would be probably caused by too much pressure in the chest besides the
Venous
barotrauma?
return.
Thank you. So yeah, so there's one in here that says interthoracic pressure, right? Increasing interthoracic pressure, which impedes venous return. Okay. What about patient riding the vent? If there's a patient riding the vent, either on or off the sedation, say they're on a rate of 20, they're breathing 20, say they're off sedation, we don't have a blood gas, what could be potentially happening?
Overventilated.
Yeah, we could be blowing off their CO2 too low, right? Especially if they're not allowing them to breathe, so we could be overventilating them. Yeah, that's a pretty common one. What about FiO₂ too high? Why do we always try to wean it fast?
Toxicity.
Oxygen toxicity. Good job, Daniel. And what is the number one answer to the educator provider? I probably get told this about 3 times a shift. Hey, did you try this? Oh,
Patient didn't tolerate.
yeah. Patient didn't tolerate. Now, I have done several classes for providers here, and they've actually brought this to my attention. And I just want to make a point. Again, I'm not saying it's a bad thing, but just in the future, if you try something and it doesn't work out or the patient doesn't tolerate, please provide a little more information of what happened. Patient didn't tolerate it, their blood pressure dropped, followed by their stats dropping because it was too much mean airway pressure. Okay. Or did you try to set it up right? Just make sure you give them a little more information, because patient didn't tolerate it. It's not the best answer. Again, as us as the experts in mechanical ventilation, we should be able to figure out the right or the best settings based off the situations on the patients, and fixing those, please, because this one is, and they tell me that when I did the last APRV class for surgery, I said, well, the RTs try it, but they tell me they always didn't tolerate it. Well, I have a lot of questions for that. We got to make sure, are we setting it up correctly? So make sure that you have more details. Now, I got 20 minutes here, so I'm going to speed up a little bit. But okay, common changes versus overdue changes. And what I mean by this is, you get a blood gas, your CO2 is up or down, you make either a rate or tidal volume change. If you have your tidal volume set at 6 mLs per kilo, then you're usually going to make a rate change, right? That's your common, straightforward change. Same with your PO2. Either your FiO₂ is weaned and or your PEEP up or down based off that. The ones I want to talk about is over here, though, these overdue changes, okay? The overdue changes, for example, is going to be the rate is still high, the patient's breathing with the vent, and you have no ABG or end-tidal CO2 for the last 2 days. Somebody needs to question that. Somebody needs to say, hey, we either need a gas, or how about just drop that rate from 20 down to 12 and see if the patient will actually wake up and trigger a breath. Let their CO2 rise. Have we overventilated them? These are the things I want you guys to focus on when you're doing your assessments, to be looking at the settings. Before I would ever do any writing down of my charting, I'd look at that. I'd look at the settings and go, is there anything I can wean before I make changes right now? Okay. And think about those changes. Same thing with the PEEP. Okay. Everybody's really good at increasing the PEEP, but nobody's good at turning it back down. Remember our baseline protocol, and this is in the guidelines right here. Our baseline PEEP is 5. We need to return on patients to 5. We start on 5. The goal is to return them to 5. Not 8, not 7, not 6. 5 is the goal, okay? And that's per both medical directors at all facilities. They've all agreed and signed off these guidelines is where we need to wean them. So when you turn the PEEP from 5 to 8 and leaving them to marinate, that's fine when they need it, but when they don't need it anymore, we need to wean them back down. And this scenario that I'll tell you is they're on 30%, setting 100 on a PEEP of 8. Okay. Then a therapist that say is fairly new is doing their daily screen and reads the question, oxygenation, says, is their PEEP at 5 or great, or 5 or equal to? And they'll say, oh no, they're 8. Well, instead of trying to wean it down, they may just check the box and say, no, they don't meet SBTA criteria. And what happens? Another day on the vent, another day in the ICU, more costs are added. Again, these are the things we need to identify. And this isn't just a day shift. Remember, weaning is not just a day shift thing either. It's a night shift. If night shift can prepare and get the patient weaned, especially if you're getting those morning gases at 3 or 4 in the morning, if you're making those changes to prepare that patient to get SBT'd and SAT'd in the morning, then again, that's that collaboration or teamwork going from shift to shift to make that. So let's go through this scenario real quick. We got a rapid response on the floors. 56-year-old male, he's lethargic, not following commands. His sats are reading 90 on 4 liters. Okay. He's admitted for ammonia. Did you guys catch that one? Just making sure you're still listening. In France, we call that pneumonia. Okay. That's pneumonia. First blood gas drawn 706. CO2 is 114. Who's panicking? Anybody? Don't panic over this. Panic over this, right? Look at the pH first. Panic over the CO2. So patient gets intubated, transferred to the ICU, placed on the vent, okay? Here's the settings that the RCP put him on. Why did they choose these settings? Are these settings appropriate? Anybody want to participate? We talked about this earlier. We need to ventilate this patient, right? So they have a high rate of 22, I agree with. PC of 22, I don't know exactly what tidal volumes they're getting, but that's probably a good amount of pressure. PEEP of 8 is probably appropriate. Again, they're hypoxic too because they're this 100%, of course. Okay, good settings. Next morning, look at that, they're dialed in. 744, 40, 333, 27. Everything's perfect. FiO₂ weaned. Everybody's good at weaning the FiO₂. Sats are good there. Okay. Now, this is the only ABG we have now in the ICU. Now we're on day 3, no follow-up ABG. The settings are still the same. What has potentially happened? Again, these are the things we need to identify. If the rate's still 22, the patient is trying to take breaths above that, probably doesn't want to breathe 22, but we're making them breathe above 22 because we haven't turned this down. PC at 22, if we're getting ideal body weight in the ventilator, I don't know what those tidal volumes are. Okay. Again, if he's 30%, sat 99, do we need the PEEP 8 anymore? These are real patients in here in our ICUs, and we need to focus on these settings. This guy had initial insult right here, the acute thing. But again, what is our goal now? Day 3, we should be weaning him. Okay. We should be following up and weaning them. So the rate was decreased to 14. Total rate came down to 18. Again, he doesn't want to breathe 22. Let him breathe and dictate his own rate. He will fix pH and CO2 if you let them breathe. And tidal volumes are actually more. It always amazes me. Some people say, how did the volumes go up when we turn things down? Well, you're giving more time in between breaths. Remember, the faster the rate, the less time in between. You're stacking things. Okay. You're not allowing exhalation, you're stacking. The more you drop out the rate, the more time, inspiratory and expiratory time you have, the more volume you get. Okay. Patient begins to start waking up, looking around, analyze the waveform. And again, just one of those things that, I don't know, maybe is it just me that it's a pet peeve of mine, but when the I time set too long, if you have your baseline here and your flow's going like this, and it's got this long pause here, and then it exhales down here. Okay, this is just wasted dead space right here. Okay. This right here, and sometimes you'll see what I mean by, like right here, where it says whoop-de-doo. Okay, that's an official medical term, by the way, for 2024. Sometimes you'll see a whoop-de-doo right here and then exhalation. This right here is telling you that the patient's trying to exhale, but the I time is too long. Okay, the I time is not set based off IDE ratio. I time should be set based off of inspiratory cycle off to baseline from expiratory. So your I time should be set from, where's my cursor? Your I time should be set from here, peak inspiratory flow, and then it terminates here at baseline. This is where I time should be set. Again, normal for adults. And again, this is out of the textbook here. And you can look at this up with several ones, setting up this. And again, setting up, again, just using, because it's a clearer picture with the 980, here is your I time. Don't set your I time based off of this, okay? Because remember, if your patient's breathing above the vent, this IDE ratio means nothing. It's irrelevant, okay? If somebody is doing assisted breathing, right? Assisted breathing, assist control, then their IDE is really here. If you look at it on this screen, and again, on the servo, it'll be on the side. I can show it to you right here on the servo, it's over here. Now this patient, again, bad example because the set rate is breathing. But the point is there's a set IDE, and you'll see in your charting, right? There's a set IDE and there's a spontaneous or patient IDE. If they're breathing above the rate, this is irrelevant. Okay, set your I time based off of flow termination at baseline, not based off IDE ratio. Okay, next patient, 80-year-old female. She's from an outside subacute. She suffered an intracranial hemorrhage in 2023, ended up being trached and having a PEG. She is on the ventilator at the subacute. She is a little old 5'1" lady. Her initial settings in the ED were placed on PC of 24, rate of 16, PEEP 8, FiO₂ 100%, tidal volumes in the 4 to 500. And I looked up, okay, 5'1", again, predicted body weight wasn't entered. And looking this up, I realized that her predicted body weight was 47.8 kilos. And her ideal 6 to 8 tidal volumes would be 290 to 380. So I don't know how many times I can say that it really helps you to put that predicted body weight. If you put that into the ventilator when you first initially start, again, if you're using PC, then this is a good way to let you know where you're at. If you put the predicted body weight, then you can adjust your PC to target those tidal volumes. Now, again, what is the rule? The golden standard is if you intubate somebody and put them on a ventilator, you get what in an hour? What's the first thing? What lab should we draw in the first hour after intubation
Blood
and
gas.
mechanical ventilation? Thank you, Elaine. Okay, ABG, blood gas, right? Sometimes that's not happening right away. Okay. And again, I just want, again, this is educational. Please take this. This is all educational. But when you have a patient who comes in at 1:30 in the afternoon and doesn't have their first blood gas drawn at 1:53 in the morning with those higher settings on a patient, this is the result of the ABG. And again, back to riding the vent or overventilating the patient. This is the reason why we want to get ABG so we can avoid this. And again, remember that alkalosis is much worse than acidosis. You know, it takes longer to compensate and come back from. And if you guys can't read this on the screen, it's the pH is 755, the CO2 is 26. Okay. So again, there was only one ABG drawn. We need to make sure we're following up on those ABG. It's the same thing we talked about non-invasive ventilation, right? In the ED, BiPAP, they've been on it for 8 hours. Nobody's got a gas. It's a ventilator. They need to be having ABGs drawn and changes made based off those gases. Again, the indications for mechanical ventilation is abnormalities of gas exchange, right? It's either a problem with oxygenation or CO2 elimination. So how do we know that if it's working? We got to get a blood gas in order to adjust the settings. Okay. So again, think about those things when you're looking at them. And so, you know, the PC was weaned from 24 to 16. Okay. And things like this. But again, I'm looking at this going, but she's still breathing above the rate. And remember, CO2 is 26. We haven't done a lot to try to let her CO2 raise. And again, remember that blood gas there. So what is another way that we could have non-invasively monitored this? We didn't have a blood gas, but what else could we have put in line just to monitor non-invasively at the bedside?
Yeah.
Yeah, remember we have end-tidal CO2 available. It's either on the ventilators or in the ICU. We've got bricks like this. Okay. And we went over this last year, but again, how to set it up. You plug in the little CO2. We have Mossmill connections. We've got adapters. We have the right parts to put in there. And you can put end-tidal on your Philips monitor bedside. And just to give you an example, you know, here's a patient that I just pulled up that's been on the vent for several days. I think it was like 34 days. It just took a section. But again, when you're documenting SpO2 and end-tidal, right here, you see a nice consistent SpO2, end-tidal, looks all normal, There's no blood gases drawn. And again, that's one of the benefits of non-invasive monitoring is because initially, yes, we need the blood gases. But when you get to a point where they're kind of like, okay, they're breathing above the vent, we're doing our weaning assessments, we're trying to whatever else they need to be fixed, they don't really need a blood gas anymore, but we still need to make sure that we're ventilating them in the right way. And the providers now, there's evidence coming out that we're trying to eliminate the number of blood sticks if we can. So how can we do that is monitoring them with our SpO2 and our non-invasive, with our end-tidal to do this. It makes it a lot easier. It's not hard, right? You grab a sample line from the stock room, go over and make sure you've got the brick. You know, make sure you've got the brick on the side with the CO2. If not, either ask one of the ICU techs or I'll tell you where they're at. They're in the drawer on some of ours, but see if you can get one of these and put it in if you need it. Oh, we also have the Rad 97s, right? We got some on stands here that we can bring to the bedside, like the similar ones we do with the either the VDR or something else. You have resources to set this up, and just remember you do have those to do. Now, we're going to wrap it up here. I know I got 7 minutes, and I appreciate you guys all hanging out with me here. But I thought this was a funny picture because it says goal for the day: do not self-extubate. And one of the things that we're going to try to talk about is unplanned extubations. Because if we're not weaning and getting our patients off, it's really, you have to remember, we're all on the clinical side, but overall the hospital's a business too, right? And they've got to make money. And patients sitting around in the ICUs, the longer they sit in there, increased vent days, ICU, and increased costs and complications for the patients. It's kind of bad for the business. So unplanned extubations, I promise you. Now, again, I apologize, Clovis. I don't have all your data put together yet, but I will share that with you maybe our next staff meeting. This is just CRMC right now. I know it's sad to say just CRMC. And if you look at the number of unplanned extubations last year for adults, it was 51 total. And just some of the data that I want you guys to I want this to sink in, because this is where this data is telling us we're missing something. Actually, if you think about it, it's kind of making us look bad, like we don't know what we're doing, and somehow we're missing clues that the patient is telling us they're ready, and we're not getting them off, so they end up doing it themselves. So, for example, out of 51 patients, only 6 of them were reintubated within 24 hours. And again, the doctors picked 24 hours. I want to say 2 of them were reintubated within 72 hours. That's still not a big number, though. That still leaves us with, what's 51 minus 8? 43? That still leaves us with 43 patients that never even saw a ventilator again. Close to shift. I thought this one was interesting. You know, when we're doing handoff during our shift change, somehow the patients know that nobody's around in the rooms and they're all by themselves, and they just somehow slide down or whatever technique they do, and they're able to pull their tube at that time is one of them. Night shift. One of the recommendations we're going back to now that we have all services in-house 24/7 is, hey, night shift, you guys can extubate, right? Do we only have to extubate during the day shift? There's 2 big published studies, multi-center studies showing that extubating at night is just as safe as extubating during the day. You all do the same thing. And again, that's why I always want to say that weaning is not just a day shift thing. We can wean them and extubate them at night just as fast either. So that's
Wait,
something.
can
Yeah, go ahead.
you educate the doctors a little bit more on that? Because so many times they're like, oh, it's already 5 o'clock. Yeah, we better wait till tomorrow. No, we're a 24/7 facility. I don't understand. So maybe they need some more education as well.
And this data I'm showing you, Nicole, was presented at corporate critical care yesterday with physicians present. So they are aware of this. We are going to have a sub work group just to try to figure out what we can do differently. But again, my number one recommendation was extubate at night, because if you guys remember, I sent you an email out to ask for replies to see what do you think the number one delay to getting your extubation order, right? That's where they meet all the criteria, they pass SAT, they pass SBT, the nurse and the RT are like, this person is ready to go. You ask the whoever, the mid-level, the resident, the fellow, whoever, and they tell you either wait till rounds, wait till the attending, I'm busy right now, whatever it is, all that was explained to them. And again, one of the ways that we can look at is the extubation at night. So yes, there'll be some education coming out if they decide on that, but be aware of that's something that could happen. Also, look, 63% of them, we're in the process of weaning them. Like I said, like some of them, the SBTs were completed in the morning, and 6 hours later, they still didn't get an extubation order, and the patient did it themselves. So I mean, I don't remember all 43 cases, but I went through pretty much all of them to try to figure out what was happening. So then we looked at location, you know, where is this happening at? And it's kind of all across the board. If you look here, 7 in ED, 7 in neuro ICU, 8 on 4 north, 12 and 4 south, 6 and 5 north, and 11 on 5. Well, wait a minute. I don't know what's wrong with the south ends here. Anybody have an answer for that one? But a few extra on the south ends there. And then if you look by service, who is the most of our ventilated business is medicine, pulmonary critical care. So I would expect them to be the highest group, okay? Because they're 60% of our ventilated patients is medicine patients, followed by surgery and then neuro. So you can see 15 of them and neuro of that. So the other interesting thing that I want to share, since we're talking about mechanical ventilation, is all of these patients, their average ventilator length of stay, so how long they were on the ventilator before they self-liberated, was just less than 3 days. This is kind of what I meant by what are we missing here? My first thought when I saw this was, is this when we first begin to start waking them up and weaning them? You know, whatever their failure was, they got intubated, we put them on the vent, we got them down on the vent, now we're going to start waking them up. Is this when this started happening and they just woke up and said, where am I? What's going on? And maybe they self-liberated. I don't know. If anybody wants to comment on, that's fine. If not, I'm trying to hurry because I have 2 minutes. But think about this. This is why I kind of sent this out as an email to kind of get your guys' feedback. I mean, I can calculate these data all day long, but what's happening out there at the bedside, you know, would be helpful if any of you want to be part of this project. You know, we've got the Code Blue BVM project going. We got the BiPAP rotational mask, just so you know, some projects. If you guys want to be interested, please let me or your supervisor know. We can get you involved, because this is another good one that they want to make a work group. to try to figure this out. And again, that's all I can come up with. So let's summarize here. I'll let you guys go. So again, whatever ventilator you have, just know it, get good with it, practice with it, know it inside and out. If you got downtime, set that thing, or if you're getting ready to go in the ICU, grab me, grab your mentor, grab somebody. Hey, let's go over this. Let's go over the settings. Get good with this ventilator inside and out. That's going to be your best vent out there, is the one that you know how to run. Settings and changes. Again, the more experience you gain, the more easier you're going to be able to see and compute these kind of changes or settings you're going to put these patients on. Think about those. If you're not sure, again, your mentors, or, I set up a patient and I'm not too sure how it looks, grab someone, grab another set of eyes. Say, hey, can you come over and take a look at this? How does this look? Does this look appropriate based off either this initial gas or whatever the problem is? Have someone else come and take a look at it. None of you guys are out there by yourselves, right? We have plenty of resources at all facilities to take a look. Again, after showing you the unplanned extubation, I'm thinking like, wait a minute, are we starting the weaning process soon enough? What are we waiting for? Because our patients are telling us that they're ready and we're missing something on that. And again, I don't know if they're making us look bad, but it's also in a good way because they're not getting re-intubated, so at least they're staying off, but we need to figure out what it is that is keeping them on. So I promise you to see you on time at 6 o'clock exactly. I don't know how I did that, but I did it. I appreciate all you guys joining me tonight. Does anybody have any questions? Is there any nurses on? Again, I can't see everybody. Oh, you know what I can do? I'll do this. I'll stop sharing so I can see now. Oh, there they all are. So for the nurses, let me talk about CE credit real quick. First of all, thank you for joining us. We appreciate you. You are our collaborative partners at the bedside. So we appreciate you joining us in these case studies so we can all, think alike and work together and getting these patients off ventilators faster. If you want to receive CE credit, again, I apologize. We don't have an online form for you. I'll have to send you an evaluation form in a Word document. So if you email me and say you would like to receive CE credit, please email me on the screen there. And I will email you evaluation, send it back to me, and then I will send you the certificate. For the RTs, you guys know where to go. Website, it's already up, ready to go. Just go to the January under 2024 and complete your evaluations. Let me check the comments. Is there any questions? No questions? Did I really cover everything? Come on. No questions, comments,
Thank
concerns?
you, Wade.
Anybody
You have
else?
a good day.
Thanks, Kent. Always good to have you here.
Hey, Wade, just a quick comment. I've been starting to do SBTs at night, even just so I can write a note. So maybe they could get extubated. I had a couple of patients that did get extubated a little earlier. Granted, one got re-intubated later on. But yeah, if they meet criteria, I just go ahead and do it, even like second round, and do it for an hour, hour and a half, and then just at least be that much more ahead, because I know we're not going to extubate at night. Like Nicole was saying, it's doctors are busy and they'd rather just wait. They always say day shift problem. So I figured if we start a little earlier, maybe we can get them extubated earlier in the day.
No, I hear you, Lynn. And I don't know. I think we'll be able to change that. Now with pulmonary critical care in-house 24/7 with an attending, I think we'll be able to change that. Because again, the majority of the vented patients are the medicine service. And those are the ones that in the past, historically, have never really been in-house. At first we didn't have any of them. We just had like some senior residents covering. And then the fellows came along and they didn't have a fellow available. But again, we know sometimes they make decisions, sometimes they don't. But then now with an attending in-house now, it might change. It might change to that point where they'll start allowing us to. And again, when I show them this data, they're all shocked. They're like, what do you mean that many? And I'm like, that's how many are out there that are getting extubated. And again, we're missing the clues to do that. And again, if any of you know what the magic or a secret trick is, to identify these patients, please share it with us so we can get them off faster. But it'll take some time, Lynn, to be a culture change. Like I know that it's the same thing. Like, oh, this patient needs a trach, but it's after 5. It's on the weekend. Let's wait till Monday. Then it's a whole nother team that starts on Monday, so they don't know the patient, so they're still not going to do it. And now you're 4 or 5 days longer now, just because of changes. So a lot of that does have to change, and it's just going to take some time to do it. But I think now with this data, we'll be able to convince them that something needs to be done. That's it. All right, you guys. Well, thanks. I appreciate you all. Like I said, please fill out the eval. It's on the main website. And I wish you all a good night, and I'll see you guys later. Take care, everyone. Bye-bye.
All right, thank you, Wade.
Thank you.
Thanks, Wade.